Assalamualaikum dear doctors. In this video I am discussing about Henotschkolin purpura HSP. This is very common come on the exams. Just I want to say it is an immunoglobulin A vasculitis. We know that it is an acute conditions and we do the investigation urine dipstick features there is present arthralgia, that is limping complaint, purpura, rash. Rash distribution is very important. Kidney effect, immunoglobulin A nephritis, immunoglobulin A involved and hypertension. So now the case. What is the exam scenario case on the history like Henotschkolin purpura? That is Omor 8 year, 1 week complaints of fever and rash. So it is an acute history, just 1 week history. At the end of the history description, I also mention 3 recalls from Henotschkolin purpura. Now, how can we take the history? Introduction is similar. Now, history of present illness, that is complaint plus review of the symptoms. Fever, we ask the OCD. When he started the fever, the course and how long he is suffering this fever. When it come, how many minutes it continue the fever. Diurnal variations like measurement method, medication given. So any medication given and it works or not, we ask how he measured the fever, high grade or low grade, we will exclude everything. Association with the fever. Is that fever associated with rigor, night sweating or any abnormal movement? Then did they all come together, the fever and the rash? So all the complaint come together or one by one we ask. Rash. From rash we analysis the OCD onset, when the rash is started, the duration of the rash. So describe the rash. Raised on the extensor surfaces of the legs, buttocks and arms with surrounding erythema. So we know that Henotschkolin purpura has a specific distributions, that is leg, buttock and arms. And distribution, is it elevated, is it itchy, does it disappear when you press on it, oozing or not, punched out lesions, crusting or not, and color of the rash. So we analyze the rash. Other concerns. Is there any dysmorphic features and chronic illness present or not, we ask. Then we go for the systemic review. The musculoskeletal system, is that any muscle pain, skin lumps, neck swelling, size, mobile, red, hot and painful, hair, nail, lip swelling, hand swelling, peeling of the skin of the hands or feet and bone. So peeling of the skin, hands or feet, by this question we differential diagnosis Kawasaki disease we excluding. Pain, we ask the pain, joint pain and joint swelling, redness, number of the joint affection, limitation of the movement. So one of the chief complaints is that he can't walk or limping. So if they complain that, then we analyze this. Now generally we ask the FWSL, we all know that fever, about the weight history, activity, sleep. L for the lump or lymph nodes plus activity, how active the child. The appetite, weight, activity and sleep are affected or not, we will ask. From CNS we ask, was vision affected, unilateral or bilateral affected, redness of the eye, hearing, fears, bug in the brain, decrease the consciousness level, ICT signs, abnormal movement, weakness, abnormal behavior and hallucinations. So we are seeing that redness of the eye, vision affected, that is conjunctivitis we are asking, and Kawasaki disease associated with conjunctivitis. Now chest infection we ask the recurrent any bug infections, cough, dyspnea, musical any sounds, contact with the COVID, smell lost or not. Now CVS we ask that any concern regarding heart racing, blood pressure, exercise intolerance, awareness of the heartbeat and pallor. From GIT we ask the tummy size, pain and its severity, poo, sore throat, lips is fissured or peeled, taste lost. Urinary system we ask the P, change in color, odor, blood, burning sensation, frothy pee, pain in the private area if male, that is orchitis, and blood pressure measured or not. So blood pressure is important in Henotschkolin purpura, we ask this. And hematology, pallor, bleeding, bruising and bug. Endocrine is blood sugar measured or not. Past history as usual 5T IOA. So 5T you know that any previous any disease, any treatment going, any traveling history, any trauma history, any blood transfusions previously, any treatment is going for his treatment, any team involved. Now IOA, you know that investigation, onset, admission. So previous disease, investigation, onset, admission we also ask. In Henotschkolin purpura, actually past history is not that much important. It is an acute conditions. So traveling, why important? Henotschkolin purpura we ask that mosquito bite, malaria, tick bites, Rocky Mountains spotted. By mosquito bite we know that lots of disease. It can be Lyme disease. It can be malaria and it can be dengue, and tick bites is for Lyme disease. So we need to exclude this. Perinatal history, birth history we will ask as usual. Party history as usual we ask. The vaccination history as usual. Allergy, if atopy, ask in detail. Allergy, March. So allergy is also important. We know that there is allergy, there is also rash develop here. Nutrition history will ask. Development history, the growth charts. Family history, that all members, any similar conditions in the family will ask. Does any family member has current COVID? Ask about their vaccination status. Or mouth sores, herpes, that is eczema herpeticum. So mouth sores will ask, by that eczema herpeticum we exclude. Social, financial, homeschool, last days in the nursery less than 2 weeks equal lies with them, more than 2 weeks no need. Then psychosocial impact, how does his condition affect the family, we will ask and end the history. Now, when someone complain this type, what are the DD come our mind? That is very important. DD of fever with rash. These are infectious cause are bacterial and viral. Bacterial are scarlet fever, that is group Streptococcus, meningococcemia, group Streptococcus. Then Staphylococcus, scarlet skin syndrome, impetigo, infected eczema, infected atopic dermatitis, Lyme disease, and cat scratch disease. So in Hennescolin purpura, we also pet history can be taken. Cat scratch disease, one of the associate with also some skin lesions. Now, viral cause are COVID, parvovirus, MMR, roseola infantum, that is 6 disease, HHV 6, chickenpox, varicella, herpes simplex, and eczema herpeticum, and malaria history. Rheumatological causes of fever with rash are SLE, GIA, that is systemic onset rheumatic fever. Vasculitis are Hennescolin purpura, Kawasaki, and PIMS. So we find the Hennescolin purpura, that is vasculitis, under presence. Hematological ITP. NAI, non-accidental injury or abuse, should be put in consideration in any case with bruises. Remember, if we find the bruise, then our mind would come the non-accidental injury or abuse. Discussion portion of Hennescolin purpura, we know that after the history, they ask us some questions. So what investigation you do for these patients? For all patients, we do the blood pressures, urine dipstick. Number 3 is if proteinuria, send urine. For early morning protein creatinine ratio, and additional investigation, what we do, that is blood test. If urinalysis abnormal or diagnosis uncertain, we do the full blood count plus blood film, urea and electrolyte and albumin level. If fever, blood culture and ASO titer, coagulation profile and throat swab. What is the indications for admission of Hennescolin purpura patient? The indications are 6. Number 1, orchitis. 2 is moderate or severe abdominal pain. 3 is arthritis involving more than 2 joints. 4 is proteinuria. 5 is clear evidence of gastrointestinal bleeding. And 6 is inability to ambulate. Refer to rheumatologist if atypical or rapidly evolving rash. Refer to nephrologist if there are 5 points for refer to nephrologist. That is number 1, urinalysis blood or early morning protein is more than 1 plus after 6 months. Number 2, macroscopic hematuria of heavy proteinuria at presentations. Number 3, hypertension. See hypertension guideline. Number 4, significant proteinuria. Early morning urine protein creatinine ratio is more than 100 gram per millimole or 3 plus proteinuria for 3 days. Number 5 is impaired renal functions. Now, treatment of Hennescolin purpura, that is admission if needed. So if needed, we give the treatment, otherwise supportive treatment, we all know that. And for joint pain, we give the NSAID, that is ibuprofen is first line, use with caution if renal involvement or patient asthmatic. So when Hennescolin purpura come, we give the treatment ibuprofen. We first, our mind, we ask the patient, he is suffering asthma or any renal impairment or not. Now, abdominal pain, we give number 1, prednisolone 1 mg per kg per day, maximum 60 mg per day for 2 weeks. Number 2, renal involvement not a contraindication. Number 3, if severe and persist, exclude the pancreatitis, intussusception or spontaneous bowel perforation. So, pancreatitis, intussusception or spontaneous bowel perforation, this should need to be excluded. And we know that intussusception, one of the complaint of Hennescolin purpura. Monitoring. When the patient of Hennescolin purpura, we monitored. This is if uncomplicated Hennescolin purpura. Example, urine analysis is less than or equal 1 plus blood and protein and normal blood pressures. Then no hospital follow-up required but GP follow-up in 1 to 2 weeks. Monthly blood pressure for 6 months and weekly urine dipstick at home until the urine is clear. Complicated Hennescolin purpura monitoring. That is Hennescolin purpura with hematuria or proteinuria more than 1 plus and normal renal function. Then as above plus routine follow-up in children's outpatients. Discharge and follow-up. How the discharge and follow-up of the Hennescolin purpura. Inform the parents. Condition may fluctuate for several months but recurrence rare once settled properly. Very rare risk of renal failure. That is 1 to 3%, hence importance of monitoring urine. Seek medical advice if child develops headache, pararectal bleeding or severe abdominal pain. Uncomplicated Hennescolin purpura, that is GP follow-up as above. Discharge from the GP follow-up if urine analysis and blood pressure normal 6 months after the onset. So if there is no complication of Hennescolin purpura, we follow up 6 months. Okay. So this is all about the history and discussion of the Hennescolin purpura. Now I am telling there are scenario and some feedback from the examiner about the Hennescolin purpura disease. Number 1, the case is that unusual rash, difference in Hennescolin purpura investigations and management plan. So it is simple. Next case is that meet the mother of a 6-year-old girl. She have Had developed a red bumpy rash on the thigh and woke up that morning with a painful and swollen left knee. Also had some abdominal pain which mom said was not unusual for her. No features of intussusceptions, no fever, no gross hematuria. Diagnosed Hanscolin purpura. So mentions JIA, SLE, septic arthritis as differentials. So Hanscolin purpura DD, what comes on our mind? JIA, SLE, septic arthritis as differential. We know that JIA history is long, that is 6-week history. Some criteria also presents in JIA. SLE, we know that rash distribution is, that is on the butterfly rash, and SLE is multi-system, loads of feature he will give. No, not this much dangerous Hanscolin purpura. And septic arthritis, we know that that is high grade fever, patient is toxic, that is presence. He can't work, unable to work. In Hanscolin purpura, patient can be limping, but in septic arthritis patient can't work. Okay, and he's crying, disturbed. So talked about the natural history, key examination findings, management. And now the feedback from the examiner about this subject. The comments is that you did not explore the concerns regarding vitamin D deficiency or address them. When you engaged patients, parents you had was in your note a lot. And the parents noticed this score. Notice this. And score was 8 out of 10. So the candidate get 8 marks out of 10, but they give that he does not rule out the vitamin D deficiency explored, and another is he was looking his note when he taking the history. Number 3, the history, how come? That is same, made the mother of a 6-year-old, the same case. Okay, so this is all about the Hanscolin purpura history and discussion. Please do subscribe and share. I am RCPCH with Dr. Emma Choudhury. Thank you.